All right, well, good morning, everybody. Welcome to the EQIP morning. Hopefully, everybody did okay with the weather. It's an important meeting today. We got a pretty robust agenda, so I'm going to jump right in and get us rolling. I got a couple reminders as we continue to have folks pop onto the meeting and we get going. The first thing I wanted to remind everybody is that as we continue the process to move towards paces, um, I would I would just remind people if they're interested in doing new bundles or interested in attempting to add folks in, this is the time that needs to occur. Please reach out to Jessica or myself so we can get something scheduled if we want to develop something new because of the timetable when things occur. The second reminder that I would like to put forward is the fact that the RFI for primary care suggestions is due next Friday. So really would ask that folks take a look at that. And if they're thinking about getting a response, please get it in for us. One of the things, two of the things the HSCRC is very interested in us doing is trying to add a behavioral health bundle of some kind or bundles and a new primary care bundle of some kind. The RFI obviously is targeted to the primary care piece, but we'd really like to get some good responses, and we're looking for some good ideas with regards to that. That is just a simple reminder. And then the other thing I wanted to do this morning, which I'm very excited about, is and while she's been with us now for a couple months, this is actually the first meeting we've had of EQIP since she's gotten here. And I wanted to welcome Krista Spiker, who joins us to lead the value-based programs with the HSCRC. Krista comes from Mathematica, where she worked on policy development and evaluation for state and federal clients and led Mathematica's primary care state portfolio, which will obviously be very helpful to us. Prior to that, Krista was at CMS for 12 years and worked on various centers, including CMCS, CMMI, and the Duals office. During her time at CMMI, she was the co-model lead for Maryland. Earlier, Krista worked for Maryland Medicaid, so that's a really nice combination for us as well as we hopefully can get some more alignment going forward. So she brings a lot of policy and program skills and a lot of experience, not only with the total cost of care, but also with Maryland specific. So we're really excited to have her on board. And on top of that, she must be really smart because she has an MPH from Johns Hopkins. So, Krista, I don't know if you want to say anything, but welcome on board. We're really excited to have you as part of the team.
Yeah, thank you so much. I'm just really excited to be here. I feel like my world has just come full circle since my days in Maryland Medicaid. So, yeah, I look forward to working with everyone and just really appreciate the introduction. So, thanks, Jean.
Well, the good news is, Krista, if you work with Maryland Medicaid, none of the technology has changed in all that time. So,
It has not.
so,
It is
uh,
exactly the same.
but no, it's really great to have you on board and welcome to
Thank
the
you.
state of Maryland. Welcome to the HSCRC and welcome to our EQIP meeting. Okay, so I have done my introduction part and I'm going to turn it over to Jessica to drive the train. So Jessica, it is all yours.
Yes, hi, thank you. So the bulk of today, we actually will be spending talking about PACEs. We'll hear from some people directly from PACEs themselves, as well as share a high level summary as far as a comparison of what PACEs looks like to our current methodology of Prometheus. So very PY4 focused, but that being said, wanted to just kind of tee up how we closed the enrollment for performance year 3. And since it just started on the 1st of this year, I'm sure people are very anxious to learn about sort of the conclusion of their list as well as when data is available. So where we ended, we have a total of 116 different entities that are participating, making up just over 3,200 different care partners. This is about a 30% increase over last year. We do have representation from 41 specialties. That's based on our drop-down list, so there could actually be more than that, or just how people are kind of self-categorized. But really happy to see kind of a spectrum of different types of clinicians who are joining the program, especially as we've added more and more episodes over the past 2 years. And we also are still seeing quite a range in size, which is also, I think, a good thing and may play into strategy and results, as we did see some of that correlation when we looked at PY1 results. So we do have some single practitioner entities going at it by themselves, focusing on what they are doing as a single practice, a single clinician practice. And then some large groups that are encompassing multiple locations. So you can see our largest group is just shy of 300 different care partners in one entity. Across the different episodes that we offer, you can kind of see that there's a wide range of participation, pretty even. Obviously, with some of our smaller specialties, we're seeing a little lower participation, but that is also to be expected. And I would also like to point out that some of our newer episodes, like MSK, we have seen a really big jump, and that's a great, I think, result and push for a lot of the outreach that was done last year. So with all of the communication at the end of December, talking about contracts, leading into the start of the year, CRISP and HSCRC essentially needed to look at the final composition of each entity's NPI list to do a secondary round of audits and eligibility. So I'll go through the 4 here, and that's sort of actively what's going on and just sort of closed out. So the first is looking at the probationary status of those PY2 providers. So as a reminder, providers were placed on probation in PY2 if they did not touch a claim in the baseline period. So because there's no downside risk, we essentially want to ensure that every practitioner who is participating in EQIP has an active role in the episode and is not just getting the perks of AAPM status and things like that, but again, actively involved in the interventions. So that's why we have that probationary status. To be removed from that probationary status, we looked at the first half of the performance year. And if a provider did touch a claim in that performance year, they're considered eligible. If they did not, they are no longer eligible to participate in PY3. They were removed. We have communicated this, and they can re-enroll for PY4. Out of all of the practitioners that were on probation, less than 10% actually fell into this not being continued eligible for the next year. So it's good to know that most of the people that were enrolled, maybe they were new from the calendar year to the performance year, which we would expect they not have claims in baseline, and they of course were involved in the episode. So that has already been communicated, and those changes were manually made in the portal. There is no next step for entities, but just wanted to ensure that they are aware of some of those changes that are happening. The next 3 is going to be communication that's just being put out, but essentially we look at volume thresholds. So we know that not every NPI that was put into the enrollment portal signs a contract. So based off of the final list of NPIs, there are some changes in volume, in eligibility based off of volume. So as a reminder, a single episode, you need 11 episodes in the baseline period, and in total, across all episodes, there needs to be 50 in the entity. So we did have some groups that fell below the 11, and we also had just a couple groups that no longer met the 50 threshold. So we will communicate that, letting you know that those that didn't meet the 50 are not eligible to participate, and those that did meet the 11, they'll be dropped from those below the 11 threshold, but will continue their participation in those that they met that minimum episode threshold. The second one we're going through is essentially circling back to that first point, but for PY3. So we're going to let you know the providers in your PY3 roster that are on probation for this first year. Again, this is not impacting any of their eligibility throughout this calendar year, but it's really looking at their continued eligibility, specifically for PY4. So kind of December of this year, we will be able to determine if they did touch a claim in the first half of this year. If they did, they're good to go for PY4. If they didn't, they would be dropped from your roster for the following year.
So Jessica,
we'll
on the volume thresholds, if an entity,
oh, thank you. You can just leave it right there. Thank you.
Oh, on the volume thresholds, if they fall below it, are they able to become part of another entity to get back above it, or could they merge with another entity? Could we do something like that for them?
So at this point, I think we we're kind of already past that point, so we need new contracts. There's quite an administrative lift there. However, when we communicate this, I think if people want to have conversations, we're certainly open. HSCRC and CRISP is certainly open to having those conversations.
So this has already happened. This is already done.
There's just a couple that we haven't communicated that yet. We just kind of ran the final audit this week. So I want to say there's 3 entities that fall below that threshold. The ones that just drop off an episode, they're still participating. It's essentially just saying, hey, you're doing 3 instead of 4 episodes. But there are a couple that fully won't be able to participate. They are small entities overall, which makes sense that, maybe one NPI that did not sign their contract had such a significant impact on that threshold eligibility. But certainly when we communicate this, I think we're happy to hear back from you all if there is something that you would like us to consider on a case-by-case basis. Well,
I would just say the 10 MedChi entities that have the smaller, well, I guess we ended up having 9. I don't remember, it was 9 or 10, whatever it was. If any of them can squeeze into there and CMS will let us do it, I'm happy to take anybody. So people can participate. Does that make sense?
Yeah, I completely
okay.
Makes sense.
If we're allowed.
Yeah. And the last one is quality metrics. So again, this does not impact your eligibility or any changes for this current performance year for PY3, but we do let you know if you are on a probationary status based off of your baseline quality metrics. And it's the same sort of thing. We're going to say, hey, you have the first 6 months of this year to improve that to have continued eligibility. I will note that for both PY1 quality probationary entities as well as PY2 quality probation entities, tongue twister there, all of them actually did improve, and we had no one who actually was no longer able to continue based off of quality. So just keep that in mind, and we'll also probably have continued conversation about what the quality metrics look like or how they're evaluated in future years. So with all that being said, all that's going on in the background and sort of, again, based off that final composite list, we are going to be able to release all of the baseline data, which does include the quality data as well, next Friday. So it'll be available by the end of the day on the 26th. And if there is any issues with accessing it in the portal, please email the EQIP inbox and we'll be able to get you some information, as well as circulate a webinar that was done last year as far as what some of the reports are to help familiarize yourself with the availability in the portal. So that was a lot, but that essentially closes out PY3. As I mentioned, really there's going to be one last communication to every single entity, letting them know these bottom 3 volume, probationary status, and quality status before the data is released on the 26th. And then those that were not eligible based off of PY2 probation have already been notified. Okay. So with that, we can actually move into PY4. So just a reminder, in November, our last subgroup meeting, we sort of introduced this idea of essentially the HSCRC, the state is evaluating the methodology for future years. And I really should say the grouper, not necessarily the methodology, because a lot of the policy will likely stay the same. But essentially, the end of this calendar year is when the contract with PROMETHEUS ends. And it's a good time to sort of take a step back and evaluate, does this grouper make the most sense to continue forward? There have been a lot of pros. It was really useful for us to kind of have this off-the-shelf grouper that we could use when we started in 2022. And it also allowed us to sort of rapidly grow. But we're really at a point where the growth, of the available episodes, and that makes sense for Maryland and our population, we've kind of really utilized all that makes sense for us. And we've had to resort to homegrown, essentially, episodes when we wanted to add. So there's certainly a component there. I think the other big things that we hear is that there is a lot of black box unknown with the methodology. Optum or Change Health does run the methodology through their own software. So there is some information that we try to understand, but is still a little bit proprietary. And then a big thing is also the limitation for them owning the methodology and the software to process that. Is that we are limited to quarterly runs. So we release the data on a quarterly basis. creating a lag. Granted, there will always be lag with claim data, but even more of a lag since there is that sort of limitation there. So those are sort of the big things. Last month, of course, we introduced PACES. There's some great benefits that when the state first had a conversation with them, primarily this lack of black box and truly promoting transparency, and the ability for the state to do that processing ourselves, which would allow us to have monthly releases of data to our participants instead of quarterly, and would hopefully just tighten that lag a little bit. Suspension still be there, but a little bit to give you guys information on a little bit of a quicker basis. So with that said, we have Ray Hirschman and Earl Steinberg from PACES. They're actually going to do an overview, give a little background about the PACES methodology, where they are today, and then we'll hand it back over to Crispin H. Metrics, who will actually talk a little bit about what this all means when it comes to crosswalking or transitioning from PACES from Prometheus to PACES. So with that, Ray, I think I'll hand it over to you.
Yeah, good morning, and thank you. Can everybody hear me okay? Terrific, terrific. Well, Earl and I appreciate the opportunity to meet with you all today, and what I'd like to do is jump in just by way of background real quick. I've been working with Earl in the episode space, 2 decades, long time, and we both started working kind of, when episode software first originated out into the market, going 27, 28 years ago. We've been heavy duty users of all the different applications out there, and one of the things that drew us to PACES was we were industrial grade users, but we had been challenged by the increasing opacity or proprietary nature of the value sets that were in the proprietary solutions, and that was becoming more and more of a challenge. The other is that virtually all the different vendors out there have switched over to a SaaS model, where you have to rely on them to run everything, their timing, their schedule, and we just were looking at the market, and I became aware of PACES back in 2019. I'll jump in right here. PACES was formed as a nonprofit. It was a spin out from an initiative that Brandeis University and Booz and several others had been contracted by CMS to create an episode grouper for Medicare. And it was, I think in a way they built a nice kind of foundational core architecture for episodes, but not surprising, it got mucked up with a lot of layers of complexity that made it very difficult to utilize. When I was aware of PACES and that we were able to put the IP from the project that Brandeis did for CMS into a nonprofit, I started digging in and trying to evaluate whether this would be a viable offering to the market as more of a utility through a nonprofit instead of a for-profit type of entity that's has different interests at hand. And what we landed on was twofold. One is the underlying architecture had some really nice elements, and I brought Earl in to really evaluate it from a clinical kind of efficacy and fidelity perspective. Separately, I looked at how the code was developed. And unfortunately, we had to recode everything. It was built in SAS. It had layers of complexity. It took weeks to run, actually. The output was good, but it was really a processing hog. So we rebuilt the application, and there's just a rules application that's a very thin, very efficient application, and then separately are the value sets. And the value sets, we call it the EDD, the Episode Definition Dictionary. We are able to update real easily. And for you as an end user, we just have to update the value sets. You don't go through a big upgrade and all the different, system requirements of a full kind of, implementation every time there's an upgrade. And what we also wanted to do was make sure that when it's deployed, it's rich enough, it has enough content. And it started off, we have about 1,100 episodes, and Earl will get some more into this. But what we did over the last year and a half or so is we had to do some serious, enhancement, enrichment of what was there, because it was built for Medicare back in 2013-14. We had to develop episodes for the commercial and Medicaid populations. We had to update the value sets to, sunset ICD-9 and be full ICD-10 current. We also just completed the integration of pharmacy data. That's separate for the broader community. I know that there's challenges in getting that type of data, but that has a big influence on spend. So we've been doing some pretty extensive material upgrades, and we're in the process right now. And Earl's leading the charge on this of engaging in a formal way with the different professional societies who are not only providing input and guidance into the episode definitions, but also helping us drive our roadmap. We want to be really dynamic and responsive to the market. And this might be also a differentiator from the more proprietary for-profit, but in a sense, this is all we do. This is the only thing we do, is to make sure that we're extending the value of the episode definitions. And we're not in any other business. We don't sell analytic business intelligence software, consulting. We don't run a SaaS. This is our pure focus is on the efficacy and the utility of the episodes. Any questions at this point? I just wanted to make sure folks had a good context of what the organization is about and our focus. No, terrific. Let's jump to the next slide. We covered a little bit about this. I think the only other thing I'll add, just for time's sake, is that another aspect that has been really important to us is, as we've been going to market and bringing this thing to a wide range of stakeholders. So there's health plans, there's provider organizations and ACOs, there's technology kind of intermediaries that support them, data warehousing, analytic vendors, actuarial and consulting firms. Increasingly, we're getting a lot of discussions with folks on the transparency and consumer advocacy side of things that want to be able to compare apples to apples on cost and whatnot. So we wanted to make sure that we're kind of intentionally neutral in who we're serving in the market. It's just the episodes. And a part of that also is one, the no black box. That not only is that not part of the deal, we give you the value sets. You have them, and we want you to be able to support your analysis so that when your provider community has inquiry about an output, an analytic, that it's easy to answer because you have the value sets. It's not in any way contained. And those are areas that obviously will never be done. We're always going to be refining and moving that forward. But this is very important to us that the value sets that drive the output is not only readily accessible, but if any of our user community have a good idea about how to improve it, we're all ears. We want to make it better. Okay, so that's important. The last is we have utility pricing, and all that means is that the more people that use it, the price goes down for everybody that uses it. Okay, so that's it. I'm going to turn this over to Earl now, and he'll speak a little bit more about the development and the nature of how we continue to improve the application.
Good morning, and thanks for inviting us. Just by way of background, I'm a general internist. I spent my first 12 years professionally on the full-time faculty at Johns Hopkins. I was a professor of medicine and professor of health policy and management, and I ran a multidisciplinary health services research unit that focused on evaluation of medical technologies and practices and on quality measurement and quality improvement. As Ray said, I've had over 20 years of experience with groupers. I've used them in projects. I was on the board of HCI3, which was the originator of Prometheus. So I've had a fair amount of experience. The key components of PACE's episodes are described on the next few slides. The first is trigger codes, which I'm sure you're familiar with. And these are ICD-10 codes in the case of condition episodes, and CPT or HCPCS codes in the case of procedure episodes that indicate unequivocally that a patient has a particular indication, has a particular condition or underwent a particular procedure. And these codes initiate an episode. Some of them, some of the episodes require a confirming claim, much as HEDIS does, so a single E&M claim won't suffice. We are moving towards enabling use of prescription drug claims as confirming claims when they are specific to a particular condition. Categories and subcategories is an enhancement that I have driven. These are subsets of an episode that reflect differences in either the type, severity, extent of disease, or comorbidities in the case of episodes. And in the case of procedures, they reflect the technical approach, the extent of the procedure, and whether particular additional procedures were performed in conjunction with them. And these are obviously helpful in enabling comparison of apples to apples and in risk adjustment. Next slide. I'm going to go first to indications here. Indications you're familiar with, obviously, these are the reasons a particular procedure might have been performed. These have been upgraded as well. And these two are useful in risk adjustments. We have not started adding relevant procedures yet. But as you'll see in a minute, we have relevant diagnoses. I have been an advocate for adding relevant procedures, and they would capture the use of particular services that appear on claims that don't have a trigger code for the episode on them. Sequelae are complications or downstream impacts or results of a disease, a procedure, or an injury that occur while the episode is open. Somebody have a question? And they can be included or excluded from analysis of the cost of an episode at the user's discretion. Next slide. I thought did I miss, was relevant diagnoses on the first one? No, so there's another component called relevant diagnoses. Relevant diagnoses, like the idea of relevant procedures, are their purpose is to capture the use of resources that are related to a particular condition or procedure, but that appear on claims that don't have a trigger code. And they can be symptoms or signs. They can be alternative ways of describing a condition or a procedure other than the one that's used in the condition definition. So there's a lot of variation in coding. You know, if you think of, for example, lumbago might appear on a claim and it's essentially equivalent to low back pain, but it's coded differently. And then certain comorbidities that don't, that aren't captured in a category are also included in relevant diagnoses. So they're very important. That's it. Any questions? As Ray said, we've begun working with specialty societies. We actually had a call yesterday with the president and EVP of the American Academy of Otolaryngology, head and neck surgery. I've been working for several months with a group of ENT experts on 2 episodes, sinusitis and chronic sinusitis and sinus surgery. We already had those 2 episodes, but I can tell you that they have provided insight about things that honestly I never heard of, and I've been practicing for over 25 years. So anyway, I strongly believe that for the validity and credibility of episodes, the input from specialists is very useful. Thanks, Jessica.
Yeah, thank you, Ray. Thank you, Earl. Really appreciate it. There's one question in the chat just asking if any payers are any payers using PACEs as a group or value-based contracts.
So let me qualify this. We do have payers using it. However, we don't have health plans contracted. They're using it through vendors, okay, that support them. But we do have 2 major national and regional payers that have completed their due diligence, and they're going through the procurement process with us. So we're young, but we have you know, what I'd say you know, significant momentum in being able to, and honestly, the biggest value drivers for them, honestly, is the transparency of the value sets, and that they can run it on their own, that they're not captive, and that you know, they've all done the comparisons like you have here and looked at, you know, what this, for a big health plan, the switching cost is significant, as you could imagine, and so they're going through, you know, the turning the big ship, you know, as part of the process. So that's a important question, and I think that we're in strong growth mode right now with health plans.
Wonderful. Thank you, Ray. And thank you, Earl. Again, we really appreciate it. I think you guys highlighted a lot of the points and considerations that HSCRC had, you know, when exploring this, and as we recommend this as the grouper we'd like to select moving forward. So thank you for that. The other thing is we heard a lot of kind of familiar terms, you know, trigger, relevant procedures, things like that, that of course are similar in terminology to Prometheus, but we would expect some differences. And that's really the main purpose of this next section. So I'm going to hand it over to Nate Hegbert, and he's going to give a high level comparison of what Prometheus and PACES looks like. We do, or there is a matching PACES episode to all of our existing Prometheus episodes. However, it is a different grouper, so we would expect some variation in the exact pricing, as well as, you know, Ray and Earl highlighted that there are some decisions that, as far as inclusion and exclusion, that could also help explain some of the variation. That's something that we can continue to have conversation about. So
yes,
again,
can I add, sorry to interrupt, can I add
no
one thing? Because I know from previous conversations that there's a strong interest in mental behavioral health episodes. PACES has 22 behavioral health, mental health episodes that include anxiety, depression, bipolar disease, obsessive compulsive hyperactive disease, psychosis, personality disorder, substance use disorders. Those haven't been reviewed yet by experts. We have welcomed the offer from you to work with a few mental behavioral health experts that you have relationships with. So while we have them, we're anxious to get them, you know, sort of upgraded, if you will, by expert input.
Dr. Steinberg, I think we've identified a few experts, and I think those meetings are kind of getting set up. So we've got
Great.
a couple psychiatrists, someone at Hopkins, and a few others. So I think we're going to do that. We're excited about it. So that's great to point out. There's also a question in the chat from Jennifer. If EQIP uses PACEs, would it still be a CMS approved model, or does it need reapproval? And obviously, I think we'd be fine, right, Jessica?
Yeah, so every year, actually, CMMI does approve sort of the changes within the program. So this is something that obviously would be incorporated into it. We have no concern that switching from a grouper, the Prometheus grouper to the PACES grouper would impact that. But every year, and that's a little bit of when we talk about timeline of decisions, it leads up to our final submission, I believe in like the May timeframe to CMMI for the next calendar year.
But just so everybody's comfortable, Will and Krista and the HSCRC team meets regularly with CMMI and lets them know what we're up to, not only with EQUIP, but with lots of things that the HSCRC is doing. So it's not like we suddenly turn an application in the spring and say, here was what we're doing, surprise. We try to work with them closely, and we're all partners. So you know, so that's kind of how it's done, and they know what we're doing, and we kind of work with them on it.
I know Liz Fowler very well. She was a grad student at Hopkins when I was on the faculty, and I worked with her there. And then I worked with her again when we both were at Anthem Blue Cross.
Okay. All right. Go ahead, Jessica.
Yeah, no. So I'm actually going to hand it over to Nate at this point. And like I said, we're going to do a sort of a high level comparison of the two different groupers, and we'll talk a little bit about next steps in kind of outreach and evaluation at a more detailed specialty level. So Nate, all you.
Thank you. Do you want to advance the slide and we will get into it? So just to level set, so we've had the opportunity to work with the PACES engineering and clinical teams for almost a year now. They've been great to work with, and we've been able to get access to the grouper to run the same data sets that we're currently using for EQIP model evaluation through it and understand what's happening. And we've really had 4 objectives in that exercise over the course of the past few months, especially as we've moved into kind of production evaluation. First, we really just want to understand how PACES differs from Prometheus and how that transition from one grouper to the other could impact participation or enrollment decisions. We understand, as has been presented, there's definitely some improvements, some changes, some realignments. We expect there to be differences, and especially with almost 1,100 episodes coming from under 100, there are going to be different categorizations, and we want to make sure that we can communicate that to this group and to everyone. Obviously, this is just the start of this conversation. As we approach the enrollment period for next year, a lot more data will be made available in the same way that it has in the past year, but just to set everyone up for a smooth transition and success. We want to understand if and how those differences will impact performance evaluation under the program, and where we need to make additional policy decisions or changes in order to ensure that we've got a nice, robust implementation and a smooth transition. And obviously, we want to be able to package all of that up and facilitate clear communication of the new system, not just to you, but enable communication to all of the downstream care partners. Overall, the result of that exercise has been, we found a really high degree of alignment between the systems. What we've essentially done is taken a frozen build of the grouper as it currently stands, and we've looked at the existing episodes that were made available under EQIP for performance year 1 and 2. Most of those episodes have undergone that additional degree of rigorous review that Earl and Ray talked about. So we're very confident that those episodes have been upgraded. And in looking through those, again, a lot of times, you know, a knee arthroscopy is a knee arthroscopy. What we pull into the episode is tweaked a little bit to better clinically and financially reflect the resources required to manage those patients. But there are a couple of key differentiation points, and it's those differentiation points that we want to talk a little bit about today. And there will be follow-up meetings with the different groups and specialists to kind of go through that in more detail. So this information is, again, just kind of a high-level introduction so that everybody has a common understanding of what we've been doing to date. Next slide, please. So first thing is just episode coverage. Again, as we get requests for new episodes, Jessica mentioned that for performance year 2 and 3, we started developing some custom episodes. Those won't be changing for right now. Right now, we really want to focus on the Prometheus episodes. And again, a big benefit of moving to this system is ultimately we get a lot better coverage. And this kind of breaks down the different categories of episodes. You can see for acute and chronic episodes in particular, while not all of those episodes have undergone final review yet, we've seen PACE's roadmap for that final review. And it's just going to give us a lot more opportunity to offer new episodes in the future without having to go through the extra development work of the HSCRC working with state stakeholders to kind of de novo develop new episodes to meet those needs. We can build off of PACEs and we'll get a lot more potential coverage under the program. Now, I do want to highlight all of the numbers in this presentation. Essentially, what we did was take a multi-year kind of merged statewide data set covering the EQIP baseline period and compared the output that we're getting from Prometheus to the output under PACEs. Obviously, for the purposes of this evaluation, there were some trade-offs we had to make in that evaluation just to make sure we were moving at a pace to meet CMS timelines. So I would just say take all the numbers with a grain of salt. They won't exactly match the numbers that you might see when we get the final official policy numbers out. But for the most part, they're accurate enough to facilitate these discussions. Any of the adjustments would be relatively minor. But I know we've got some keen-eyed folks who keep a close eye on all the numbers. So just know that these will shift a little bit, especially since, as Earl and Ray mentioned, the version of the EDD and the grouper that we will end up using for next year will be an evolution of the current build. We'll arrive at kind of a frozen build that we use for each performance period. But we've got a little bit more time to incorporate changes like those additional behavioral health episodes potentially before we freeze it for performance year 4. Next slide, please. So again, this is just speaking to, if we look at procedural episodes specifically, a lot of the current episodes that are offered are procedural. We just wanted to understand, with the expanded range of episodes, what's our potential coverage for the program. EQIP is a model under the total cost of care waiver. The state of Maryland is responsible for generating savings across the board for Medicare. Ultimately, how many beneficiaries, how many dollars can we touch? And so we've done a number of different analyses just to kind of see what that changes. This is just one example slide kind of showing how many more potential beneficiaries are touched by this specific subset of episodes and how many dollars are potentially in play. Again, it just gives us more rationale, especially when we're talking to CMS, to go through and say, here's why we want to move from one system to the other. And we think it'll be to the benefit of stakeholders and care partners as well, that ultimately we're going to have more available to tailor to the real on-the-ground care redesign interventions that all of the EQIP entities are undertaking right now. Next slide, please. So I think this slide and the related ones that'll come out in the more detailed meetings to follow are really what folks are going to be interested in. Now, obviously, if and when we move forward with the new grouper, everyone would receive new target prices completely under the new methodology. So right now, we just want to understand, okay, what's the difference between what you're seeing now and what you would see in the future? It's not that we're going to take your existing target price under the old grouper and use that with the new one. It'll be kind of a blank slate. But we want to be able to help folks understand, okay, in performance years 1 through 3, I was participating in, for example, in the arthroscopy episode. What would that look like under the new grouper? And again, for a lot of these episode categories, we see a pretty high degree of consistency. And after next week and in the following weeks, we're going to make episode playbooks available. So if you're interested in seeing exactly what gets pulled into some of these, you can do that. And obviously happy to talk more if folks have specific questions down the line. But again, for a lot of these, you know, if you look at the episode volume, if you look at the target price, the total dollars under the system, they're pretty closely under alignment. And where there are differences, our assessment is that for the most part, those differences make sense. If we see an increase in episodes, a decrease in target price, the differences between Prometheus and PACEs are helping us to better tailor to the clinical and financial realities of those procedures. And again, during enrollment, all of the volume numbers, the target prices, the baseline costs for your entity would be made available so that you can review those before you make any new enrollment decisions. Now, the next few slides, again, what we wanted to highlight are the differentiation points. And we'll go through a couple of kind of key case studies for how they differ. I'll call attention to, or if you go back one slide real quick, colonoscopy. Those of you in the GI space, you might have noticed, hey, there's a pretty big difference there. We'll explain why that difference exists, and again, what some of the policy decisions we can make available during enrollment that either help explain why that difference exists or bring the numbers closer into parity, in that case, by potentially rolling in additional related episodes that Prometheus is kind of under the hood grouping together right now. And again, as the note says, this is just a base level comparison with the assumption and understanding that we would make some of those decisions and lay them out clearly to participants. So when you enroll, you've got a clear roadmap from the old system to the new system. Go ahead to the next slide. So one other piece that is going to differentiate is just the base episode parameters. Again, we can talk in more detail as we move forward about any of these, but in some cases, the difference in the target price or the episode volume is simply going to be, we're looking at a different global period, a different look back period for the episode. And that's just going to change the amount. So if you have a longer episode period, the dollars included in that bundle will increase. If it's a shorter period, obviously it's going to get smaller. But did just want to highlight there are small differences like this. In some cases, you'll see the episodes are exactly the same. In other cases, they will be different. And again, this is just a subset that we're working from that were available during performance year one because it gave us a really good basis for presenting the comparison. We've been doing our evaluation on a much broader set of episodes, but especially for the ones that aren't currently in the program, we want to keep the conversation focused on what we need to know to get to performance year 4.
Nate, can I just mention that
Yep.
in PACES, all 3 of these parameters are customizable by the user. So if anybody wants to change how long an episode is open or how long a look back period is, it's a simple adjustment.
Right. And I'll note as well, like, you know, we've been working with Earl and Ray for a long time now. They've been really receptive to input and feedback. So again, we think we've got a very robust, stable basis here. I'm willing to stand behind these episodes the way that they're defined. But if we do, as we move forward, see that, oh, there are improvements that can be made or tweaks that can be made, again, we can entertain that discussion within reason. I don't want Krista and William to, you know, throw the bus at me if we open too much of the doors for modification. But I do think there's a lot that can be done as we look forward to the future of the program to make sure that the definitions that we're using meet the needs of the state, stakeholders, and CMMI in, you know, meeting the end goals of EQIP as a program.
Yeah, Nate, this is William Henderson from HSCRC. I would just, confirm your sort of needle, right? We don't want to get into hyper customizing and changing every episode window, but certainly are looking if there's logical places. You know, I think the one that leaps out here, right, is the difference in episode lengths on the colonoscopy and the endoscopy. So as we meet with that specialty, you know, I think something like changing the episode lengths there would definitely be on the table, but you know, I don't want to start tweaking every episode length.
Yep. All right. So again, a case study in some of the decision points that we'll have and that we'll discuss moving forward. I kind of characterize this as episode differentiation and categorization. And again, if we're moving to a grouper that has 93 episodes and a relatively low proportional coverage of total cost of care, to a system that with 1,100 episodes and an aim ultimately of covering 100% of spend for medical care for a given beneficiary, there are going to be differentiations in how those episodes are characterized. And I called out colonoscopy earlier because it's a relatively straightforward comparison to make. So in the current version of the grouper, The PACES colonoscopy episode, when we look at the codes, is really focused on diagnostic and therapeutic colonoscopies specifically, right? So if we want to include sigmoidoscopies, screening colonoscopies, other procedures that might have a different cost profile, we can do that. We would just be adding in those additional episodes as offerings in the enrollment. When we compare the strict bundle right now, however, a lot of those procedures under Prometheus are just implicitly bundled up into a single procedure. So that's why we have the difference in procedure volume and the difference in target price here, because we just wanted to say, okay, when we're talking about the colonoscopy episode writ large, how do those two compare? And so what we'll be doing is going through each of the episodes and mapping out what the most reasonable relationship between existing Prometheus episodes and the existing PACES episodes are. We'll present those, and what we'll probably either end up doing is just giving the option to enroll in those multiple different episodes, or for the sake of convenience, if everyone concurs, hey, it makes sense to keep these all together, we can modify the enrollment suite so it's very easy to just enroll in those multiple related episodes as a single episode category, again, with the goal of just facilitating a smooth transition while not losing any of the benefits that we get from the more differentiated episodes that are available under the PACES grouper. And again, some of these things are also open for feedback and refinement. Again, we want to be careful how much we do that, especially for the first year of the program. But we can talk a little bit more about this. But ultimately, the differences come down to the fact that the episodes within PACES are a bit more carefully targeted around a given resource profile so that we're not implicitly mixing higher and lower resource intensity procedures together without understanding, hey, this is exactly what we're doing, and here's why that's happening. Next slide, please. So another key differentiation point, and this one gets a little bit more difficult to understand just because of the way that Prometheus handles this particular case, is associations and sequelae under PACES versus episode levels under Prometheus. So if you're familiar with the Prometheus grouper, what it does is it's implicitly rolling up episodes between different levels in the grouper logic, which allows for the construction of what I would characterize as higher level episodes, which includes all of the acute episodes like that for AMI. The PACES episodes are all explicitly standalone episodes, so you can look at each PACES episode on its own. And then, as Earl mentioned, those are linked together by different episode associations, indications, sequelae, pulling in relevant diagnoses as needed. And then we can use those links to incorporate or differentiate different approaches, procedures, or intensities as needed. So a good example of that, again, is this AMI bundle, where under Prometheus, if we look at the existing volume, we've got about 503 episodes. If we look at that under PACES, we do get these different breakout episodes. We'll provide additional guidance on kind of the nomenclature for episodes, but as a general rule, if you see TP at the beginning of an episode code, that's a procedural episode. CA is going to be an acute episode, and any episode beginning with an X is some sort of combination episode where we're explicitly acknowledging that multiple different things happened, and those are going to have a different profile than a standalone procedural episode by itself. But essentially what we need to do is go into those associations to be able to pull out all of these different approaches to addressing AMI in order to kind of reconstitute that volume. And there's a couple of different ways that we can do this. I don't want to go into them in a lot of detail right now, but essentially the approach that will give us the closest approximation to Prometheus is essentially rolling these different associated episode costs into the target episode of interest and allowing participants to enroll in that episode with the associated costs. That way, the care partners who are attending to these beneficiaries get responsibility for the entire designated condition, while also being able to call out the fact that there are different profiles here. But again, this is something that we'll be talking with the cardiac specialists to come to a final decision on. And we'll have a bit more information, more granular information about exactly how this is working as we move forward. Next slide, please. Okay, so I think that's it. Again, there will be a lot more data to be coming, and I will say one slide that didn't make it into this presentation, but we can add to it after the fact, is just kind of a high-level evaluation of if performance year 1 had been conducted under PACES rather than Prometheus, what would it have looked like? And again, one of the things that gave us a pretty high degree of confidence in the system is we saw net similar levels of savings, i.e. the EQUIP entities that generated savings under Prometheus are still generating a similar amount of savings under PACES. And those that were unsuccessful, again, were unsuccessful under both systems. So we're not seeing a big shift whereby a entity that was successful under Prometheus is all of a sudden unsuccessful under PACES. That was one of the things that we did want to make sure that we looked at. Again, the numbers do change because we're including different components into each of these constituent episodes. And there is, where we have those different categorizations, a final determination will depend on how we end up characterizing enrollment for the new program. But again, savings levels for a simulated first year of the program were largely in line between the two. And again, that's part of the reason that we're having this conversation today, to continue moving forward with this presentation and evaluation. So with that, Jessica, I think I am done. I'll hand it back to you. And again, we'll make more information, including the episode playbooks, available in the coming weeks so that folks have those available for review, and we're making full use of the transparency that PACES has to offer.
And just quickly, Nate, I think we have got some times held for special meetings around specialties if they want to look at and have a discussion around the crosswalks. So I obviously I was glad you pointed out the GI one, because I do think that's one that we need to work on, given the fact that it's so different. We need to make it more aligned so we don't have a major change. And I think when we look through the rest of the crosswalk, there was a lot of similarity, but we really want to have those higher level discussions. So we'll be getting those dates out to the group once we know what they are based on some of the specialties.
Yeah, Jean, that's a good lead in, because really essentially we're talking about next steps. I think, we introduced this a couple months. Hopefully this gives people a little bit more confidence and familiarity with how PACES is developed, and some of the key things that we're looking and need to consider, and especially some of the decision points that need to be made between now and sort of the enrollment cycle. But essentially, sort of the next 2 months, February and March, is really that detailed level outreach and education. So our goal here, I have 4 tentative dates. We will send out calendar invites once we have firmed that up. But ideally, they will all happen in the month of February. If we need to lean into March, we will. But essentially, we're going to look at not every specialty, but a couple different specialties, especially those that there are some large differences between the straight relationship between Prometheus and PACES, and have a more detailed walkthrough of the different groupers and what some of the decision points that we need to make. There is, as I think I've mentioned, there's a lot of flexibility, but I think there needs to be some consensus across how we enroll, meaning that some people, can't say, well, I'm going to group a sequela in for me, and other people aren't going to. It is something that we sort of want to come to a consensus with, and would love stakeholder input on that. So that's really what the focus is going to be next month. Ideally, I think we're going to focus on like GI, cardiology, ortho, and urology, I think, are the ones. We certainly are happy to have other conversations. And like I said, as we push more information out to you all, if there are questions that arise, please reach out to us, and we can also look to see if there's other specialties that may make sense. But we are really looking into really that end of March timeframe to have some final decisions about what specific episodes we will be including under the PACES groupers, as well as decisions as far as any associations or sequelae or things like that, which would lead into our enrollment in July. So a lot more information to come. Hopefully you all have absorbed some of that now. And like I said, we can give some information out to give you a little bit more time to digest and look at some key questions that you would like us to address as we continue to have these conversations. And then finally, the last plug is, I think we mentioned earlier, we really are kind of coming into this the time frame of adding new episodes is getting very short. If there are specifically PACES episodes that we could use a clinical expertise to help validate and sort of be able to deploy next year, that is the preference. But even that requires some time and coordination. And as mentioned, it seems crazy, but March, April timeframe is very close. So we are hoping to have those started as soon as possible if there is interest from stakeholders about that. So I think that's all we have. Obviously, we'll welcome questions and push out recordings of this and slides, as well as the calendar invites for the next couple of sessions where we go into more depth. And just a reminder, we do have we decided to have another subgroup meeting, larger subgroup meeting on in February. I think we're going to shorten that to just an hour though for some updates, and we certainly will push out more information when we get closer. So I think that's it, unless Jean, HSC.
No, just I would note on the meetings that the February meeting's an extra meeting. We normally meet every other month. So for those of you on the calendars, just note that we're doing that just because we've got so much work to do with regards to the RFI on the primary care issue, and then all the work with regards to the grouper transition, if that's our plan. So that's it. All right.
Yep.
Well, thanks, everybody. Enjoy the
Thank
snow.
you.
Thank you.
Thank you.